Hello, my dear friends. Our topic for presentation today is cholangiocarcinoma. What exactly is cholangiocarcinoma? It is the cancer of the bile ducts. So, cholangiocarcinoma is bile duct cancer. We will explore the topic under the following headings. We will discuss the surgical anatomy of the liver and the biliary tract, the embryology, risk factors of cholangiocarcinoma, clinical presentation, how to diagnose cholangiocarcinoma, how to stage the cholangiocarcinoma, pathology of cholangiocarcinoma, and management and follow-up of cholangiocarcinoma. Coming to the segmental anatomy of the liver. The liver has the right lobe and the left lobe. The segment 1 is the caudate lobe, and the left lobe of liver has the segment 2, 3, 4A and 4B, and the right lobe of liver has 5, 6, 7 and 8. So we can see a clockwise rotation like that, 2, 3, 4, 5, 6, 7, 8. So that is the segmental anatomy of the liver. Now, how does the biliary tract drain these segments? We can see this is the common bile duct. After the joining of the cystic duct, it's the common bile duct, the common hepatic duct, the right main hepatic duct, and the left main hepatic duct. The right main hepatic duct has two tributaries. One is the right medial or anterior hepatic duct. So the right medial hepatic duct drains the segment 5 and 8. We can see on the right lobe, the medial part is segment 5 and 8. So the right medial hepatic duct drains segment 5 and 8. Coming to the right lateral hepatic duct or the posterolateral duct, right posterolateral duct. The posterolateral segments of the right lobe are segment 6 and 7. Though see, these segments are drained by the right posterolateral duct. Now coming to the left lobe of liver, the segment 4, it drains segment 2, 3 and 4. 2, 3 and 4 are drained by the left hepatic duct. Now the caudate lobe, the lobe 1 is drained by, has tributaries, the biliary drainage is by the right main hepatic duct and the left main hepatic duct. So this is the biliary tract drainage of the different segments. So the biliary tract is divided into the extrahepatic biliary tract and intrahepatic biliary tracts. The extrahepatic biliary tract include the right and the left hepatic duct, the confluence of it. This is the hilum. This part is called the hilum. The common hepatic duct. The cystic duct from the gallbladder joins the common hepatic duct to form the common bile duct. This is the extrahepatic part of the biliary tree. Coming to the intrahepatic part. The intrahepatic part includes the secondary radicals. That is, after the division of the common hepatic, of the divisions of the right and the left hepatic duct, which is inside the liver parenchyma, which drains bile from the different segments of the liver, includes the intrahepatic biliary tract. The arterial supply of the biliary tree is by the hepatic artery or the branches of it. So, gallbladder is supplied by the cystic artery, which is a branch of right hepatic artery. The right and the left main hepatic trunks are supplied by the right and left hepatic artery. There are branches from the common hepatic artery to the bile duct and common hepatic duct. And the distalmost portion of the bile duct is supplied by branches from the gastroduodenal artery. The venous drainage is mainly by the branches of portal vein, right gastric vein, superior mesenteric vein, and the pancreatico-duodenal vein. Lymphatic drainage is important because when there is cholangiocarcinoma, there is metastasis into these nodes. So we have the hilar nodes here near the confluence. In the calyx triangle, we have the cystic node or the lymph node of Lund. Then we have the pancreatico-duodenal nodes here, and all these drains into the celiac nodes. Coming to the embryology of the biliary tract. So here we can see the foregut, the hepatic diverticulum developing from the foregut. This is the ventral mesentery. The hepatic diverticulum is in the ventral mesentery, and this is the dorsal mesentery. We can see the biliary tract branching like that. The hepatic diverticulum branches like that and forms the liver and the biliary tree. So these are the different stages where we have the hepatic diverticulum initially to a fully formed liver, gallbladder and pancreas. How does this happen? So the hepatic diverticulum towards the ventral mesentery, the branching of the biliary tree starts. So here we have distinction into the hepatic cords here and the gallbladder here, and a dorsal pancreatic bud is developing here. We can see the liver, the gallbladder, the cystic duct, and the ventral pancreatic duct is in the ventral pancreas is developing in the hepatic diverticulum, whereas the dorsal pancreas is developing from the dorsal pancreatic bud. Now this is the fully formed liver with gallbladder, cystic duct, the common bile duct draining into the duodenum. We have the ventral pancreatic duct, ventral pancreatic bud, which has formed into the ventral pancreas, and it is joined with the fused with the dorsal pancreatic bud, forming the pancreas and the uncinate process of the pancreas. So all these are draining into the duodenum. That is the development or the embryology of the liver, pancreas and the hepatic ducts, and liver, pancreas and the biliary tree. Now coming to the cholangiocarcinoma. So to understand the cholangiocarcinoma, cholangiocarcinoma can be anywhere in the biliary tree. So as an arbitrary division, we can divide the cholangiocarcinoma, the biliary tree, into three parts: the proximal, the middle third, and distal. It is divided into one third, one third, and one third. The proximal include the proximal part, the cholangiocarcinoma in the middle part is rare. The proximal part can be the perihilar. This is the perihilar region near the hilum and the intrahepatic ducts. And this is the distal part. So distal part is generally periambulary carcinoma. It comes under the periambulary carcinoma most probably. And two-thirds of the cases are at the bifurcation. That is Klatskin's tumor. It is also called the Klatskin's tumor. So proximal, middle and distal. In the proximal, perihilar and intrahepatic. Distal is periambulary. So 70% of tumors occur in the perihilar region. The intrahepatic component is 10%, and the periambulary or the distal cholangiocarcinoma includes the 20%. So this is the distribution of cholangiocarcinoma in the biliary tree. Wherever the cholangiocarcinoma is, the cholangiocarcinoma generally has a dismal prognosis. The risk factors of cholangiocarcinoma: chronic inflammation of the biliary tree and compensatory cellular proliferation is the basic cause for cholangiocarcinoma. So what are the causes of this chronic inflammation and proliferation thereof? One is choledochal cyst. What is choledochal cyst? It is the problem with the wall of the biliary tree. There will be fusiform dilatation or saccular dilatation of the walls of the biliary tree. It can be both intrahepatic and extrahepatic. What is the cause for it? We can see there is a pancreatic duct and the common bile duct drains into a common channel. So we have the sphincter of OD here. So if the sphincter of OD is tight, what happens? The pancreatic juice will go into the biliary tree like that. So if the pancreatic juice goes into the biliary tree like that, there will be destruction of the walls of the biliary tree, causing it to dilate like that. This is considered as the basic pathology of choledochal cyst, and this results in inflammation. The exposure of biliary tree to the pancreatic juice results in chronic inflammation of the biliary tree, which can result in cholangiocarcinoma later. Next is the liver flukes. What are the most common liver flukes? They are the Clonorchis sinensis and Opisthochis viverrini. So we get it from the fish. Second intermediate host is the fish, and from fish we get it reaches man. So liver flukes are a cause for chronic inflammation. Brown stones are associated with liver flukes. Pigment stones, hemolytic. Brown stones, which are infective stones, is associated with the liver flukes. Black stones are hemolytic stones. And the yellow stones are the cholesterol stones. So, chronic inflammation from liver flukes. Now, recurrent pyogenic cholangitis. This is stone formation and the superadded bacterial infection causing inflammation of the biliary tract, destruction of the walls, forming recurrent pyogenic cholangitis. Another one is an autoimmune cause. Autoimmune cause and destruction and sclerosing of the biliary tract, both intrahepatic and extrahepatic. There will be duct strictures and fibrosis. Primary sclerosing cholangitis is cause for that. Other risk factors of cholangiocarcinoma are an earlier dye which was used as intravenous dye thorotrust, oral contraceptive pills, asbestos, and cigarette smoking. All these are risk factors of cholangiocarcinoma. Now, how does cholangiocarcinoma present? The patient presents with icterus. There will be dark colored urine. This is a normal urine, and this is the bilirubinuria, which is a dark colored urine. Then itching, the patient will be always itching. That will be the main complaint of the patient. Patient will be more bothered about the itching rather than the discoloration of the eyes. The itching is generally due to the bile salts. The discoloration is due to bile pigments. The itching is due to the deposition of bile salts in the skin. And clay colored stools. Since no bile is coming to the stools, there is no stercobilinogen to color the stools. To color the stools as yellow, so it will be clay colored stools. So obstructive jaundice, clay colored stools. Now there is a cholangiocarcinoma can be either extrahepatic or intrahepatic. So distal cholangiocarcinoma, the distalmost cholangiocarcinoma presents early because there will be earlier onset of this jaundice and obstructive features and clay colored stools. So they will present early. Whereas the proximal presents late. Why? Because the biliary drainage is not blocked. Only some part the biliary drainage is blocked. So the liver function may be affected a bit, but it is not completely affected. So it will be covered by the hypertrophy, compensatory hepatic hypertrophy of the opposite lobe. So the proximal presents late and the distal presents early. Now, is there pain in cholangiocarcinoma? Generally, there will be no, it is a painless jaundice. But if there is a pain in cholangiocarcinoma, it means there is perineural invasion and it points towards an advanced cholangiocarcinoma. Before going any further, let us understand where does this bile pigments and bile salts come from. Bile pigments are heme degradation products. The degradation of the erythrocytes results in heme. Heme becomes biliverdin to unconjugated bilirubin. This unconjugated bilirubin is not water soluble, but it is in combination with albumin, can travel in the bloodstream and reaches the liver, where it is acted upon by the UDP glucuronyl transferase and becomes conjugated bilirubin. Conjugated bilirubin is water soluble. It is excreted into the bile and it reaches the intestine. Conjugated bilirubin in the intestine is acted upon by the intestinal flora and becomes urobilinogen. 20% of it becomes urobilinogen and 80% of it becomes stercobilins. The stercobilins is excreted through feces and which gives a yellowish color to the feces. If conjugated bilirubin is not coming into the intestine, what will happen? There will be no stercobilins in the feces. So then the feces will be clay colored. There will be no yellow colored. Now coming to the urobilinogen. If the urobilinogen 95% is excreted, 95% is reabsorbed through the enterohepatic circulation and rest the 5% is excreted through the kidney. But what will happen if there is obstructive jaundice? The cholangiocarcinoma, the conjugated bilirubin will not come to the intestine. There will be no urobilinogen and the urobilinogen will be absent in urine. So in obstructive jaundice, the urobilinogen will not be present in urine. Where does the bile salt come from? Bile salts basically comes from cholesterol. How? Cholesterol is degraded into cholic acid and chenodeoxycholic acid. They react with taurine and glycine to become toro or glycocholic acid. or toro or glycosinodeoxycholic acid, and this is secreted into the intestine. What happens in gut? The gut microbiota acts on it, and this bacterial enzyme will convert into deoxycholic acid, ursodeoxycholic acid, and lithocholic acid. These are the bile salts. These bile salts, more than 95% are reabsorbed into the portal vein via enterohepatic circulation and reaches the liver. Rest of the 5% is excreted through feces. So what happens in obstructive jaundice? This is not going into the into the bowel. So this sodium glycocholate and taurocolate, they will get refluxed into the bloodstream, and this bile salts get deposited in the skin, causing itching. Now imagine yourself in that OPD and the patient is coming to jaundice. The prehepatic causes and the hepatic causes of jaundice are mainly managed by medicine, whereas obstructive jaundice comes into the surgical terrain. So when a jaundice comes to you, will you send the patient to medicine or will you send the patient to the surgical OP? How will we decide? For that, LFT comes to our help. So what are the components of liver function test? Bilirubin total and direct. So total means indirect plus direct and bilirubin direct alone. Then AST, that is SGOT. Then ALT, that is SGPT. Alanine transferase, total protein, serum albumin. Alkaline phosphatase, gamma glutamyl transferase. That is a classical LFT. Prothrombin time will also help us to understand the liver function test. Liver function. Now, what is the use of bilirubin total and direct? It quantifies the degree of any suspected jaundice. These two enzymes, AST and ALT, are markers of hepatocellular injury. Total protein and serum albumin will help us to understand the synthesizing function of the liver. And alkaline phosphatase and gamma glutamyl transferase are increased in biliary obstruction. So does this help us to differentiate the jaundice? Not yet. So normally the bilirubin is less than 2. Total bilirubin should be less than 2. In obstructive jaundice, it may be raised more, the bilirubin total may be raised more than 10. So whatever, then we look at the amount of direct bilirubin. The direct bilirubin can be any value. It can be 1, 3, 6 or 8, any value. So what should we see? We should see the relation between the total bilirubin and the direct bilirubin. If the direct bilirubin reaches less than 20%, it is only less than 20%. Suppose the total bilirubin is 10 and the direct bilirubin is only 1. That is, it is less than 20% of the amount of total bilirubin. It means that it is an unconjugated hyperbilirubinemia. If it is more than 50%, say the bilirubin is 10, total bilirubin is 10 and the direct bilirubin is 6 or 8. So it is more than 50%, it is conjugated hyperbilirubinemia. Okay, it will be generally conjugated hyperbilirubinemia. So if it is less than 10%, it is unconjugated hyperbilirubinemia. If it is more than 50%, it will be generally conjugated hyperbilirubinemia. So if it is the direct bilirubin is less than 20%, it will be generally due to hemolytic causes or prehepatic causes. If it is more than 50%, it will be due to obstructive causes. Thus, we can decide whether this patient can go into medicine or whether the patient should go into surgery. What about the in-between cases, 20 to 50% cases? It can be predominantly hepatocellular causes or there can be an obstructive component to it also. So that the 20 to 50% jaundice, think about hepatocellular causes more, but rule out obstruction anyway. So this is how we decide whether a patient should go into medicine or surgery depending upon the relationship or the percentage of the direct bilirubin towards the total bilirubin. So then how will we understand whether that is the 20 to 50% is due to obstruction or is it due to hepatocellular cause? Look at the liver enzymes. If the SGOT and SGPT or the AST and ALT are elevated, that means the cause is a hepatocellular injury because they are markers of hepatocellular injury. So if AST and ALT are elevated along with the 20 to 50% direct bilirubin, it means the cause is hepatocellular. Also look at the alkaline phosphatase and gamma glutamyl transferase. If the alkaline phosphatase and gamma glutamyl transferase has raised, it more points towards the biliary obstruction. So that is how the in between 20 to 50% jaundice, we will make sure whether it is due to a hepatocellular cause or due to a biliary obstruction. But what is the role for this total protein serum albumin and prothrombin time when we look for liver function? When the total protein marks the albumin marks the liver synthesizing function. So if the since the half-life of total protein and albumin are more, for its level to get decreased, the liver function should be affected for some time. So if total protein and albumin are low, it means it is a chronic liver disease. But the half-life of the clotting factors are less than 8 hours generally. So if clotting factors are not synthesizing properly, but at the same time total protein and albumin are normal, it means that it is an acute liver disease. So if total protein and albumin are low, it means it is a chronic liver disease. If only prothrombin time is affected, but total protein and albumin are normal, it means it is an acute liver disease. So this helps us to understand whether the liver disease is due to an acute cause like a paracetamol poisoning or a rat poisoning, or is it due to a chronic cause like a hepatitis, like a chronic hepatitis or cirrhosis. Now coming to the other diagnostic investigations. The tumor markers. Normally in liver tumors, the tumor markers like AFP may be raised. But CA, CA99, none of the tumor markers are all the tumor markers are unreliable in cholangiocarcinoma. It is no use with it. So it is generally not recommended. Now coming to the imaging. The basic imaging is ultrasound examination. What will we see? It may show intrahepatic biliary tree dilatation. Intrahepatic biliary tract dilatation. We'll also call it as IHBRD. Now, whether the extrahepatic biliary tree will be dilated, when will we know that the CBD is dilated? If it is more than 8 mm diameter, it means the common bile duct is dilated. So a tumor which is in the intrahepatic region or in the proximal region, only some part of the intrahepatic biliary tree may be dilated. But if it is in the distalmost portion, the extrahepatic biliary tree will also be dilated. So this is a normal liver and this is a normal kidney. Normal liver, we can see the biliary tree. So in the affected kidney where there is cholangiocarcinoma or there is obstructive jaundice, we can see the intrahepatic biliary radicals are dilated. In obstructive jaundice, there is always a confusion. Is it due to stone or is it due to a mass? Or is it due to a cholangiocarcinoma? So how will we know? Especially when there is cholangiocarcinoma, there is a problem. It will not be easy to understand between structure, stone and cholangiocarcinoma. Of course, the Courvoisier's law come to our help. If there is a palpable gallbladder in a patient with obstructive jaundice, it suggests a sinister diagnosis. So if the gallbladder is palpable, it is more towards malignancy. In case of a stone, there will be previous inflammation and the gallbladder will be shrunken. So that helps, but there is always exceptions for Courvoisier's law. So we have to distinguish whether it is a stone or a mass. Now, where exactly is the cholangiocarcinoma? Is it intrahepatic, or even if it is extrahepatic, it is in the distal part, or is it in the hilum? We have to know where exactly is cholangiocarcinoma. And if it is a mass, we have to understand what is the staging of cholangiocarcinoma and what is the resectability of cholangiocarcinoma. Is it resectable or not? So how will we investigate this part? For this, MRCP, magnetic resonance cholangiopancreatography. So we have to see the biliary tree. So how will we see the biliary tree? The non-invasive method is MRCP. So in MRCP, we can see the biliary tract like this. This is a case where there is hilar cholangiocarcinoma. There is no filling here, no enhancement here, no bile here. So that means it is a hilar cholangiocarcinoma. MRCP can help us to understand the location. Now, cholangiogram can be done in different ways. It can be also done by endoscopic retrograde pancreatico cholangiopancreatography. So, but the problem is we have to put a scope, endoscope, and we have to put the scope here near the opening of sphincter of Oddi, and we have to inject the dye to visualize the uh, biliary tree. We can see here that this is the tube. We can see here that there is no filling of biliary, no filling of the dye here, and this part is dilated. So that means there is a distal obstruction. What is the advantage of ERCP? One, that if there is obstruction, it can help us to stent. We can put through an ERCP, we can put a stent across the lesion, and we can help in biliary drainage. Another advantage is that if it is a lower tumor, we can take a biopsy. So this is the distal bile duct obstruction seen visualized here, and we can see that the stent is placed here. We can see the stent placement, and we can see the lesion here. We can take a biopsy from the lesion also. Next is we can see the difference in imaging. There is another method, percutaneous transhepatic cholangiography. So we can do cholangiography by MRCP. We can do cholangiography by ERCP. We can visualize the biliary tree. Another one is percutaneous transhepatic cholangiography. Suppose if the biliary tree cannot be visualized, if we cannot pass the dye through the sphincter of Oddi due to obstruction, what can we do? We can put a needle through the liver, reach the biliary tree, and inject a dye. We can see this is the needle, and we have injected the dye to see the biliary tree. This is a normal percutaneous transhepatic cholangiography. But when there is obstruction, this is a fluoroscopy view, this is the X-ray view. When there is obstruction, we can see there is non-filling here in the hilum, the right and left hepatic duct, and the hilum there is no filling of the contrast material. So percutaneous transhepatic cholangiography is another method of cholangiogram, another method to visualize the biliary tree. Hilar cholangiocarcinoma. Now, which is better? These are both these are ERCP images, and this is an MRCP image. Which is better? Always endoscopic retrograde pancreatography or percutaneous transhepatic cholangiography image is much better than MRCP. If the location is not clear in MRCP, we can always try an ERCP or a PTC to identify the level of tumor, identify the location of the tumor. Now, staging and resectability. Staging, it is T, N, and M. So liver metastasis is best seen in CT scan. We can also see intrahepatic biliary radical dilatation in CECT abdomen. But staging of cholangiocarcinoma is different in different locations. Coming to the staging. The staging for cholangiocarcinoma is different for intrahepatic lesion, for perihilar lesion or the Klatskin's tumor, and for the distal CVD lesions. So coming to the staging. So this is the liver and the biliary tree. Suppose T1. T1 means the tumor has not invaded any nearby blood vessels and it is a solitary tumor. T2 means there are multiple tumors and it is invading the blood vessels. T3 means the tumor is going extrahepatically. And T4 means there is periductal invasion. So this is the staging for intrahepatic bile duct cancer. So there is coming to the nodes, N0 means there is no regional lymph nodes cannot be. N0 means no regional lymph node metastasis, and N1 means regional lymph node metastasis present. Now coming to the staging of perihilar bile duct cancer. So it is a perihilar lesion. So this is the division of the bile duct. The division of the bile duct, the Klatskin area, the hilum happens there. This is the hepatic artery branches on both sides, and this is the portal venous bifurcation, the portal venous branches. So how is the perihilar lesions classified? So in stage 1, the cancer has grown into the bile duct wall. So the fibrous layer of the bile duct wall is affected. Now it has gone beyond the duct wall to the adipose tissue around or into the liver parenchyma around, that is T2. T3 is it is affecting the Ipsilateral, the cancer is growing into the branches of the main blood vessels of the liver, either to the branches of the portal vein or to the branches of the hepatic artery. But it is affecting only one side. The rest of the part of the liver is normal. We can preserve, we can live with that much part of the liver. Now coming to the T4 lesion, it is the tumor is invading both the hepatic arteries or both the veins. That is, none of the liver is not salvageable. It is difficult to salvage the liver. Both lobes of the liver are affected. So that is regarding the perihilar cancers. Now coming to the nodal status, N0 there is no regional lymph node metastasis. N1 there is regional lymph node metastasis along the cystic duct, common bile duct, hepatic artery and portal vein. And N2 the next level of vessels, the superior mesenteric artery and the celiac trunk vessels are affected. That is regarding the perihilar bile duct cancer. Staging of the distal bile duct cancer. Here we can see the distal bile duct, its wall, pancreas and the celiac trunk. So T1, the tumor is confined to the bile duct histologically. T2, the tumor invades beyond the wall of the bile duct. T3, it invades into the adjacent organs like pancreas, gallbladder, duodenum. And T4, it involves the celiac axis or the superior mesenteric artery. N0, there is no regional lymph node metastasis. N1, there is regional lymph node metastasis. So this is a picture of a tumor infiltrating the portal vein. So with the help of CT scan, CCT abdomen, we can understand the amount of infiltration of the portal vein, and it helps in the staging or the disease. Now the next question is the tumor is resectable or not? Resectability is this much important in cholangiocarcinoma because other modes of management like radiotherapy and chemotherapy are not very much effective. How will we decide whether it is resectable or not? So, when is the tumor not resectable? Let us read through. Bilobar intrahepatic metastasis and any extrahepatic disease. Involvement of bilateral secondary biliary radicals. Engagement of main portal vein. Bilateral hepatic lobar artery. Lobar atrophy with involvement of contralateral portal vein or biliary radicals. What does this mean? It means that after adequate resection, will there be any liver left, any functional liver left? So if there is bilateral intrahepatic metastasis, after removing both lobes, there will be no liver. Involvement of secondary biliary radicals, multiple small radicals are affected. No liver left. Engagement of main portal vein. The portal vein has to be removed. No liver left. Bilateral hepatic lobar artery involvement. No liver left. Again, lobar atrophy. One lobe is atrophied, the other lobe is involved by the malignancy. Then again, and also again, no liver left after resection. Why not? Why can't we do hepatic transplantation? Hepatic transplantation is not used. We cannot be. It is still in an experimental phase in cholangiocarcinoma. So it is actually kind of a contraindication in case of cholangiocarcinoma. So these are the indications. These are the conditions in which the tumor is not resectable. Now coming to the tissue diagnosis and cholangiocarcinoma. Wherever in breast, in thyroid, we have preoperative staging, and then we preoperative tissue diagnosis, and then we go in for surgery. But tissue diagnosis before resection in operative patients is unnecessary. Why? Because the other mode of treatment will not do much. Anyway, you have to go for a surgery. Anyway, you have to relieve obstructive jaundice. So we have to go for a surgery. So and also negative cytology report does not exclude malignant disease. So tissue report is diagnosis not necessary. When is the tissue diagnosis necessary? Establishment of a tissue diagnosis is important only when the patient is not a surgical candidate. If the patient is not a surgical candidate, very old, then we have to go for the very old, or we will not go for a surgery, or it is not resectable, then we have to go for other modalities of treatment, even if it is not effective in a full extent. So then we have to think about tissue diagnosis. Now, what else? Preoperative biliary drainage and cholangiocarcinoma. You see, these patients with cholangiocarcinoma comes with a total bilirubin of maybe 20 or 25 like that. Their clotting parameters may be abnormal. Their nutrition may be abnormal. There will be fat soluble vitamin deficiencies. So, can't we do a preoperative biliary drainage, relieve the obstruction, make the patient better, and then go for surgery? That is again a point of debate. Why? Because preoperative biliary drainage, liver function can be better and we can wait till the proper time of surgery. That is the advantage of preoperative biliary drainage. What is the disadvantage? It has more infectious complications. Cholangitis can happen. So more infectious complications postoperatively. But is biliary drainage is in any part important in case of an intrahepatic biliary cancer, or in case of a intrahepatic bile duct cancer, or in case of a cholangiocarcinoma where hepatic resection is required? In those cases, preoperative biliary drainage is good, and we can make the clotting factors normal, and there will be no coagulopathy, and the additional risk of bleeding or sepsis or hepatic failure will be can be alleviated if in cases where hepatic resection is needed. So biliary drainage is better in those cases. After preoperative optimization and correction of coagulopathy, we will go for a surgical management. So the principles are: exploration should proceed even in the absence of a confirmed tissue diagnosis. And we are not confirming by tissue diagnosis, around 7 to 15% of the patient undergoing resection can have a benign disease. And cholangiocarcinoma always have a dismal prognosis. 50% of the tumors will be unresectable during exploration. So during the opening of abdomen in case of cholangiocarcinoma, always there will be an element of surprise. When we see the cholangiocarcinoma, there can be different morphological subtypes. If it is an intrahepatic or a proximal cholangiocarcinoma, it can be either a mass-forming lesion or it can be a sclerosing lesion along the ducts with periductal fibrosis. If it is a distal lesion, it can either be firm or soft intraluminal lesion. If it is a firm, will be a nodular type pathologically. If it is soft, it will be a papillary type pathologically. But the decision of the surgeon on what type of resection, on what type of surgery we should perform will depend upon: is it a proximal intrahepatic lesion, or is it a proximal perihilar lesion, or is it a distal lesion? So what surgery will be performed in each of these cases? By a rooftop incision, we generally approach a case of cholangiocarcinoma. So what if it is a distal cholangiocarcinoma? What will we do? We do the Whipple's procedure or the pancreaticoduodenectomy. It can be treated like a lesion in the head of the pancreas or in the periambulary lesion where there is a distal tumor. So we have to tie the gastroduodenal artery. So when the gastroduodenal artery is tied, we have to remove the head of the pancreas, the distal CBD, the jejunum and the distal ileum. And after that, we will do a reconstruction. So we have the stomach open here, the common bile duct is open here, and the pancreas is open here. When the stomach will be open here, the pancreas will be open here, and the CBD will be open here. So we will do a choledocho jejunostomy, a pancreatico-jejunostomy, and a gastro-jejunostomy. So the treatment of distal cholangiocarcinoma is pancreatico-duodenectomy. Coming to proximal cholangiocarcinoma, resection of the regional lymph node tissue en bloc with resection of common bile duct and hepatic parenchyma is necessary to achieve margins. So lymph node has to be dissected along the common hepatic duct, and the resection of the tumor has to be done along with the liver with a margin. So in case of proximal cholangiocarcinoma, it has to be individualized depending upon the amount of liver which is left behind and the function of the liver. So the treatment has to be individualized. The general principle is lymph node removal with the surrounding liver removal. What will we do when it comes to perihilar lesions? Perihilar lesions, the management differs. So it can be a type 1 lesion where the cholangiocarcinoma is just reaching up to the hilum, or it can be a type 2 lesions involving the hilum type 3 lesions extending into the right hepatic duct, type 3 extending into the left hepatic duct, and type 4 extending into both hepatic ducts. So what will we do in these cases? In type 1 and 2 lesions, we can resect the lesion. So there will be a stump of two hepatic ducts or a stump of the common hepatic duct here. So we can reconstruct it by Roux loop of jejunum. So there will be resection, there is a resection component and there is a reconstruction component. We have seen the reconstruction in component in case of pancreatic duodenectomy. Now we have to do with reconstruct with a Roux loop of jejunum. Roux loop, always Roux loop is a confusion. So just let me just explain what is a Roux loop. So after the resection, there will be a stump like this. Roux is a surgeon. It is a Cesar Roux. Cesar Roux. So what will we do is we cut the jejunum like this, and we bring the with the stapler we can cut like that. We bring this part of the jejunum towards the biliary tract, biliary tree, so the bile can drain into the jejunum. Now this part of the jejunum is free, so that we anastomose to the remaining jejunum, so the bowel content can go. So this is the Roux loop. The this is the Roux and Y, the Y loop. This is the Y shape here, the Y loop of Roux. Now, what will we do when it is a type 3 lesion, when it is extending to the hepatic duct, or it is extending to both hepatic ducts? So they involve complex individualized resection of portal vein, hepatic artery of both. Negative margin status is the most important thing associated with outcome. Transplantation is generally not done. It is still in the experimental stage. Now, we know that 50% of the tumors are not resectable during exploration. But the patient is having jaundice, the patient may be having pain due to perineural infiltration, or there can be a duodenal obstruction in case of a large tumors. So what will we do in those cases? We have to palliate the lesion. Even if the lesion is unresectable, surgery is not stopping there. We have to go for a palliation. Palliation can be either a surgical palliation if we are understanding the resection, understanding the unresectability of the tumor at the time of surgery, or preoperatively if we understand that the lesion is not resectable, we can go for endoscopic management. Surgical palliation can be by cholecystogeginostomy or choledocogeginostomy, but endoscopic management is better. So relief of jaundice. It can be either done by a cholecystostomy or it can be done by a placement of the metastatic stent. Only if the cholangiocarcinoma is distal, cholecystostomy can work. But if the cholangiocarcinoma is proximal, then we have to do a percutaneous transhepatic biliary drainage. Okay, so either we can keep a self-expanding metallic stent through ERCP. If it has to be drainage, if it is a proximal drainage, if it is a distal cholangiocarcinoma, we can do by a cholecystostomy. If it is a proximal one, we have to do a percutaneous transhepatic biliary drainage. That is how we can do a palliation in case of jaundice. Now you have to alleviate the pain. The pain alleviation can be done by oral narcotics, IV narcotics, or percutaneous destruction of celiac plexus. So a needle is inserted posteriorly near the spine towards the celiac plexus, the nerve plexus around the celiac trunk, and the alcohol can be injected for alleviation of pain. Now, how will we relieve the duodenal obstruction? Again, an endoscopic duodenal stenting can be done, or we can do a surgical palliation by gastrojejunectomy. So, surgical management is over. Now, what about the medical treatment? So, there is no use with chemotherapy or radiotherapy. So, if it is an R1 resection where there is microscopic deposits in the remaining specimen, in the remaining liver or in the remaining biliary tree, then we can use radiotherapy. What about the outcome? The outcome will depend upon the stage at presentation, the negative margins, and cholangiocarcinoma is considered as a contraindication for transplantation, and the prognosis of cholangiocarcinoma is generally poor. Now, We have discussed about the surgical anatomy of cholangiocarcinoma, the different parts of the biliary tree, the embryology, it is developing from the hepatic diverticulum, the risk factors of the cholangiocarcinoma, inflammation of the biliary tree, clinical presentation, obstructive jaundice, itching, diagnosis by MRCP, ERCP, PTC, CT scan, LFT, staging of the lesion, the three types of staging, and the management of cholangiocarcinoma, both the surgical management, the palliation, and the medical management. With this, let me conclude. Thank you.